All right, we are recording. Welcome to our presentation for today, our third in series of 4 CQM trainings brought to you by the Department of Health and Human Services in Texas. Before we get going, I'm just wondering if there are any words of welcome that Julie would like to share.
Sure. Good morning, everybody. Thank you so much for joining us this morning and spending an hour with us to learn more about performance measurement as it relates to CQM. Happy New Year to those of you who I haven't been in touch with since the new year came, and happy Friday. I'm really looking forward to this. I know this is one of the areas of CQM where we struggle the most around in Texas. The good news is our new system should be coming live in 2021 at the end of spring or beginning of summer for some operational items, and it'll progress throughout the next year and a half. So thank you.
Fabulous. Thanks so much for that, Julie. And we're so excited to be here with you. With me, I have my colleague, Jasmine Black, who's going to be tag teaming the presentation with me today as we walk through our presentation on CQM performance measures and data activities. And please excuse the buzzer in the background. All right, so just a couple of hints, reminders. We're using Zoom. You should be in full screen right now, but you can hit escape to have a window that then has your toolbar visible on the bottom. If you hover over the top of the pictures, you can change the view options as well. So you can either have a film strip, or you can hide the pictures, or you can keep up the Brady Bunch. Something that we'd like for you to do is to include, to have the Brady Bunch view up with your camera on when we take the slides down for the group conversations. That's going to be really helpful for us to really be able to interact with each other better. We ask that folks keep themselves on mute until we're ready to pose a question, or you can make a comment or to react. But please do use the chat room to pose questions and make comments throughout as well. And we're going to be looking in the chat room to pull your conversation forward as we go. We're already recording the conversation today, and this is going to be put on our unlisted YouTube channel with the other presentations. And just a reminder that you can find a link to all of the previous presentations in your email. And everyone, by the time we get to the end of February, everyone who attended any session is going to receive a master email with all 4 links and the toolkits, links to those toolkits. That way we can spare you your time and energy and your sanity later down the road if you're trying to find any of these resources. The last thing that I'd like to just point out is if you can enter your name and where you're joining us from in the chat room, that's really helpful because it helps us to connect faces with names and where we're calling from in case there are any folks that we're not familiar with. So our learning objectives for today. We want you to be able to explain how services provided in your service area affect the HIV care continuum. We want you to be able to describe the concept of a medical neighborhood. We'd like for you to be able to list mechanisms used for experience evaluation activities. Following this presentation, you should be able to explain the difference between operational and performance quality. You should be able to describe your specific tie that your regional CQM activities have to play into achieving together statewide. And we're going to be exploring that a lot today. So if we get there and you feel as though it's still kind of a dotted line, that's okay to share. This is very much a safe space, and our goal is to help you to become more closely tied to achieving together. So don't be nervous. And then finally, we'd like for you to describe your role as an AA, as a coach for CQM performance measurement and QI. So as I mentioned, we do have quite a tall order for us to cover in today's webinar. And we're really excited to have you with us as we dive into this conversation that's really important to the care we provide across Texas. So I'm going to turn it over to, oh, actually, no, this is me talking about administrative agencies. I like to keep Jasmine on her feet. I'm going to talk about administrative agencies, CQM performance measurement, and quality improvement. And In order for us to do this, there is a poll. So I am going to launch this poll. And Jasmine, why don't you walk us through the poll we have?
Absolutely. Hello, everyone. So the first question on the poll that should have appeared on your screen is, do you have a CQM performance measurement data collection plan for your region? So then we just have a yes, no, or I'm not sure. Question 2, do you conduct regional QI projects with the expectation that all subrecipients in your region participate? And do you provide QI method and other capacity building opportunities for subrecipients in your region? Looks like we have about 25% of the vote in this time. %.
This is such a great way to interact with you and kick off our conversation, just to have a sense of the lay of the land in Texas. Thank you so much for responding to these polls.
Looks like most people have CQM performance measurement data collection plans. That's great. We're at about 62% of the vote entered.
Does anyone else want to weigh in on this? All right, let's end the polling and share the results.
All right. 71% of people say they do have a CQM performance data collection plan. 67% of people do conduct regional QI projects with the expectation that all subrecipients in the region participate, with about 14% of people saying they're not sure there. And then number 3, do you provide QI methods and other capacity building opportunities for subrecipients? And about 62% of people do. We do have about 24% of people who are not sure.
Great. Thank you so much for sharing that with us. And it's great to know that a lot of you do already have the framework in place for you to be able to champion and to coach your subrecipients in your administrative areas around this. What we wanted to do was just kind of go back and provide a quick recap on the PCN 1502 requirements here. CQM performance measurement is required per PCN 1502. And for any service category where more than 50% of all Part B supportive consumers receive at least one service, we need 2 measures. If between 15 and 50% of all Part B supported consumers receive at least one service unit, 1 measure. And if fewer than 15% of all Part B supported consumers received at least 1 unit, no performance measures are required. And the important thing to remember about this is that this is at the Part B recipient level, at the state level. This is about utilization at that level, and you don't need to then further calculate at your own levels as an administrative agency, what that would be. And you certainly don't need to have a service provider level or a sub-subrecipient level analysis. What you need to do is to tie your expectations for Part B to what comes from our Part B partners. And just a little bit more nuance before we look at how this shakes out in Texas. For the focus, our measures should focus on improving patient care outcomes or patient experience. We need to collect our measures at least quarterly per PCN 1502. And ideally, we would like to have a system that can help us to conduct health disparities analysis to really help us to segment that data for that purpose. So what we're looking at now is how this shakes out in Texas. We have all of the Part B data aggregated and showing us how many units of service were provided, so that we're able to then calculate the percentage of clients that received at least 1 unit of service. We have the unique client count, the percent of the total, and the unique utilization of service. So we can see that the measures that are required here are for APA, non-medical case management, medical case management, outpatient ambulatory health services, and referral for healthcare. And you can see our state partners have even told us here that how many measures this equates to. So we have one measure each for APA and non-medical case management and for OAHS. And we have 2 required for referral for healthcare. Now, interestingly, medical case management didn't rise to the level that we're required to have a measure, but PCN 1502 only tells us what's minimally expected. And our state partners have determined that it's really important for us to go ahead and to have this ARB prescription measure for medical case management. So that, of course, is the next piece for us to view here. We can see which performance measures have been identified by our state partners that are the CQM performance measures for these service categories. So ARB prescription is what we use for APA, retention of care is what we use for non-medical case management, ARB prescription, again, for medical case management, viral suppression for outpatient ambulatory health, and both retention of care and viral suppression for referral for healthcare and supportive services. It's really important for us to keep in mind that as administrative agencies, then this is at a minimum required for the funded subrecipients in our areas. And so if we do have subrecipients in our service areas that are funded for any of these highlighted categories, we must collect the measures that are indicated here on a quarterly basis. Having a data collection plan, to that end is something that's very, very helpful. And you could have this as a part of your quality management plan as an attachment, or it could just be something that's a standalone separate document. The important thing is to have a place where it's written down what the expectation is, and you can then mark and track people's ability to meet those expectations. So for quality improvement, subrecipient level QI projects are required using a standard QI methodology. And again, this is going back to the learning that we had initially for what is PCN 1502 and what is expected of us in terms of our CQM activities as administrative agencies. So the DSHS preferred methodology is the model for improvement. And as such, it's recommended that you use the model for improvement in your administrative agency's service area to champion quality improvement activities, and that you provide training around the model improvement to help emphasize the state's preferred model. The organizational assessment supplements the model for improvement and is critical to overall program and system evaluation. And this is, Jasmine's going to get into this later, but this is starting to talk about the little bit of a difference, right, between performance quality and the operational quality. Subrecipients are required to implement QI activities that are aligned with the recipient's QI activities. So if the state, as DSHS says, that there's a QI activity or a QI project, it's incumbent for each of you as administrative agencies to identify how you're going to bring that to life for the service providers that are funded by Part B in your service areas. And it would make sense then that your coaching would be about translating the state's vision for QI activities into what is happening on the ground, and that you would also then be translating what's happening on the ground and making connections for these agencies back upwards to DSHS. So your role as an administrative agent here really is to kind of be a translator and a middleman between what the state is expecting and requiring and what the subrecipient or the provider agencies are actually doing on the ground in the field. So let's just recap this one more time. PCN 1502 and service providers who are actually subrecipients in your case. Recipients, so the state, is expected to provide guidance to subrecipients on prioritizing measures and collecting data. Check, we just saw that, right? The state has provided the methodology used to identify what measures, and they told you what measures for what service categories. Check, check. Recipients, so the state, need to work with subrecipients to identify improvement opportunities and monitor quality improvement activities at subrecipient locations. So this happens in multiple ways, right? The state has a CQM committee that brings together all of the different perspectives of what's happening at your subrecipient, at your administrative agency level, and the service providers that are happening, that are providing services in your subrecipient area. And the state is also, in charge of the syndicate. So that's another source of information that the state has for its decision-making process. And of course, that is really the root of thinking about how statewide level CQM activities will then be attached to achieving together and ending the HIV epidemic, right? Because they can be a central source of information for this, for the decision-making process to occur. And yes, and the prioritization of CQM activities would be coordinated across Ryan White recipients in their jurisdictions, and subrecipients funded through the recipient. So this training series is a CQM activity, right? Because we're building all of your capacity and we're providing a baseline, the state's providing a baseline for all of you for the level of coaching that you can provide to the service providers in the field. And the state has also prioritized the CQM activities by providing those measures. And also they have prioritized CQM activities by creating those mechanisms for achieving together. So you can see here that the system really is designed in Texas to help bring, the expectations of quality to life, but really with the purpose of what we are trying to do as a service system. And that really is to end the HIV epidemic. So our focus multiple times has been to point out that what we do in quality is not monitoring and evaluation. It's not. What we do is that we focus on QI, and everything that we've talked about so far and everything that we're going to continue to talk about should emphasize our focus on QI. It's about helping endpoint patient outcomes. It's not about yardsticks, hitting wrists, or anvils falling from the sky to crush Wile E. Coyote. It's all about improving endpoint HIV health outcomes. So we've already emphasized a little bit about how this works in Texas, that HRSA is the funder, DSHS is the recipient. You all are technically the subrecipients as administrative agencies, and the providers that you fund within your service areas are the sub-subrecipients. And so it's really important for us to keep in mind what our role is in terms of, again, translating the vision and the expectations from our state partners and bringing them to life for our providers. Things get to be a little bit more complicated when our AA is also a Part A, because our AAs that are also Part A's then are recipients in their own rights, and then come up with their own methods, their own CQM performance measures, and their own activities to help bring PCN 1502 to life. And when we think about the way that we're structured in Texas, a very wise and measured way to go about this would be to think about how what we do as our administrative agency really adds to what the state's trying to do overall. And it's important for us to think as large metropolitan areas in some cases, that what we do should complement and not be in conflict with what the state is doing. Because when we do something that's in conflict, then we make life hell on the ground for our providers, because the providers need to follow the guidance and expectations laid out by both Part A and Part B. The chat room is very, very full. So I'm going to rely on people to help call forward questions that are occurring, because we might have some at this point.
There's been one question, but Julie just answered it in the chat.
Oh, cool. Thank you so much. All right. So let's look at this. Again, we're talking about CQM performance measurement. And even in terms of thinking about CQM and quality improvement, there's information that needs to be transmitted, right? Like, we can't just collect this information and sit on it. Part of the story and part of the process is to share it forward. So how does this information get shared forward, and to what end? This hopefully will help to demystify why we report certain information to whom, when, how, and why. Our subrecipients are producing quarterly CQM reports as required by contract. They're also producing ARIES performance measurement data. They're also conducting experience evaluation. They're also providing QI project updates. They also have QM committees, and they also have organizational assessment results. Materials from all of these activities are then shared with you, or they should be. And what you do with this material is that you take this information and you repackage it for the RSR. And you repackage it for the purpose of having monitoring calls with the subrecipients to provide them with further guidance and resources that will help them to augment and enhance their QM activities. You may have an internal QM activity committee. You definitely have an external QM committee. And you may have planning council and task force activities that rely on the reports that are coming from subrecipients in order to do priority setting and resource allocation, in order to propose policy and rule changes in the way that we are allowed and permitted to do business. But basically the idea is that the information from subrecipients are then all used, 100% used by the AAs. And that these AA activities then translate into things that are done at a high level. So HRSA and HAB even have reports that they're responsible for doing. So they take the RSR and they turn that around and make state profiles that they share with the public. You can Google that, RSR state profiles, if you haven't already. It's a wonderful set of information. They are on the hook for congressional oversight, not fun stuff, and executive oversight, also not fun stuff. When the HHS secretary can literally call in Laura Cheever and say, what's going on here? Texas Dishes also takes the information that you're submitting to them as an AA, and they use that to help generate the templates and the process to have Achieving Together and to create their EHE plan as a state. And for some of you that have a fast track city coordinator, you're also then generating this additional information. This slide really is to show you the pathway of how information flows from subrecipients through you as an AA, and what your role is then, in bidirectionally with subrecipients, and thinking about what you owe dishes and what you owe HAB if you're also a Part A. So let's just look at your dishes contract components one more time. We provided boxes around the areas within your contracts that actually point to how this is required. So all subrecipients and provider agencies have to sign on the dotted line that they're going to collect and report all required ARIES data, and that they have a method to validate that data. They all have to have care continuum and other data that are stratified to identify disparities. They all have to provide updates on program progress to all their stakeholders. And they all need at least one QI project that's ongoing and linked to one of DSH's 4 strategic domains. There it is, black and white, right in the contract. Just wanted to pull up this document one more time as well in terms of thinking about how we use data for improvement. It's this box over here, second to the right. As AAs, we kind of act like department managers or directors. And what we do is we aggregate unit processes and outcome metrics. So we aggregate what's happening at the subrecipients in the field, the provider agencies in the field. And we're also then providing updates and metrics to our supervisors in DSHS and in HAB. And we're also responsible for staff QI capacity. This, I think, is a very important piece because it speaks to your role in providing these key resources to subrecipients in the field. And it is, in fact, your role to do that, to be able to identify what is needed in terms of specific capacity building, and then to go ahead and deliver that. So let's look at this again. What your AA role, knowledge check. You should be asking yourself, do any of the services provided by subrecipients in my service area have required CQM performance measures? And if yes, We need to create a system by which subrecipient agencies in the service area submit those required performance measures to you on a predetermined schedule. Again, data collection plan, written instructions, what is the mechanism for you to collect the data? And ideally then, part of this process would be having a sense of how you share this information back with the people that are submitting it to you, so that we do have a bi-directional communication pathway and people don't feel like they're throwing information into a black hole. Something on AA scale. So the AA scale is not important for performance measurement. The PCN 1502 framework is at the recipient level, at the state level. You are all, agents of the state, and therefore it doesn't matter who's providing what in your service. The only thing that matters is who is providing what in your service area. And if they are providing services that are required for there to be measures, they're on the hook to do that. But the scale of your AA is important for QI. Regions with Part A are more likely to provide more concretely defined QI activities than regions without Part A, because the Part A regions tend to be more tightly defined, and there are additional resources because they are a Part A entity that go into helping to create that project. Agencies without a Part A tend to be much larger, and there aren't as many resources. And because we're talking about a larger area, there's a lot more variability in the types of services provided, the types of agencies where services are provided, and the type of consumers that are receiving those services. With these areas that are not Part A's, we need to be able to think about this in a way that allows our funded providers to fit in the project. So this is an area where the scale of the AA is important for QI. If we're talking about an area that's not a Part A, we need to be able to think about this in a way that allows for everyone to fit. And we probably can't be as concrete, because that concrete would then not allow everyone to fit. I think you're always well served if you can consider and keep going back to the question, how can our local QI activities help us all in achieving together to end the HIV epidemic? So that was an awful lot on CQM, performance measurement, and on QI, and the specifics of the requirements as it relates to your role. We haven't gotten that much into, the mechanics, of like, what is data? What is QI methodology? And Jasmine's going to dive into that with you more deeply. But we wanted to just take a moment to see if you have any questions or concerns that you'd like to flesh out related to what is expected.
Michael and Jasmine, can you talk more about administrative agencies that are multi-funded and how they would select performance measures, like Tiffany's question, if they're a direct recipient of C, D, or A? And then from your slide about following the utilization performance measures from Part B, then how do they incorporate their other funding into that? Did I answer it correctly is what I'm trying to get at in the chat? That they use their own data, but they should try to align with Part B? Would that be the correct direction to give them?
Yeah, absolutely.
Okay.
I think the important thing is that you align, and this is where we were talking about before. If your Part A has a similar breakdown of service utilization, so your Part A would then say that you're also required to have a certain number of measures for the same category. There are different reasons why strategically you could choose the same measure, or strategically you could choose a different measure. It all depends on what you're trying to examine and what that might mean for the way that you're going to plan out and evaluate future services. It's a great question.
And for most of our services, prescription to ARV, viral suppression, and retention can be used in general, right? There are those outliers like transportation or food bank where you can connect them if you have the lab data. So there's all kinds of ways to do this.
Yeah.
Keep the questions coming. I'm surprised it's so quiet. No
Looks like
questions?
we have a question about how explicit does the data collection plan need to be for Part B?
So I would advise you to think about what is going to be most helpful. So that is providing enough detail and structure that people get it, but not providing so much that we've now lost it all in a sea of words and narrative. My recommendation would be to try to have, to fit on one page if possible, the measure definitions. You would want to talk about the data collection frequency and the method by which data are collected. So we have a preferred Excel sheet, or you may submit the data in any way that you see fit, for example. To say that we have our quarterly deadlines for data to be collected. These are the cutoffs. I think that's an important thing. I think also explaining that if people have a different way of thinking about this measure, please reach out to us. For example, viral suppression, some people have a cutoff of 400 instead of the traditional typical cutoff of 200. Some people say, we don't follow unsuppressed, we only follow undetectable because the literature tells us that any viral load is hazardous to, viscera over time. So there should be room for subrecipients to have conversations with you about the specific way that a measure is calculated and what that means. And I think that you should allow for a certain level of flexibility that makes sense, that allows for agencies to be able to provide their services in a way that fits their vision and mission, but that also is similar enough that it doesn't invalidate your full data set. Really important to remember, quality is not research. We don't need to have fidelity be so rigid that it has to be just so, otherwise we're not accepting it. We need to be flexible enough to allow for individuality and for there to be customization appropriately in the field. And this becomes, I think, even more important for those very, very large areas that have many different types of agencies that provide services to many different types of clients. I hope that answered your question, Bob, but if not, let us know and we can certainly try again. Now, in the interest of time, I'm gonna go ahead and move forward. Is that okay, Julie?
Yes.
All right, and this time I'm gonna turn it over to Jasmine to walk us through these next sections.
Yeah, so we're going to walk through some examples and discussion around quantitative and qualitative data. Oh, can you lead us in a poll?
I sure can. So this next poll, are quantitative performance measures in your region all related to the HIV care continuum? Yes, no, or I'm not sure. Have you worked with subrecipients in your region on experience evaluation measurements? Yes, no, I'm not sure. And do you have confidence in the CQM performance measurement data you have available in your office? Yes, no, or I'm not sure. All right, we have the votes pouring in. These questions, I think, are really important to our processes. So definitely feel free to weigh in here candidly. That will definitely help us. Let's see if we can get up to 65% again. If we chase in about 4 more votes, we should be good.
Who's there?
2 more. All right. Yeah, let me end this poll.
Like voted out, yes.
So I'm sharing the results now. 65% of you say that all the quantifiable quantitative performance measures are related to the care continuum, and 27% said no, which is interesting. And I wouldn't be surprised if, the fun word there is all. So probably, even among those of you who said that they're not all related to the care continuum, some of your measures likely are. And I don't think that there's necessarily, a reason why we have to be tied to the care continuum. There are so many reasons why we might focus on something else. Have you worked with subrecipients in your region on experience evaluation? 54% said yes, and 23% said no. I'm a person living with HIV myself for almost 20 years. So I'm always a big believer in this and the importance of making sure that we have experience evaluation. So maybe you'll pick up something new from our conversation today. And do you have confidence in the performance measurement data in your office? More than half said yes, and 23% said no, and 23% said unsure. And of course, as we know, this is one of the biggest challenges that we have in our field, right? And one of the reasons why it's important not to be super rigid with our expectation for the fidelity to a certain process, because that is one of the things potentially that spins us out, that we won't have faith in the data because people aren't able to do exactly as we say. They can't jump as high as we want when we want them to. So I'm going to stop sharing results and turn it back over to Jasmine.
Thank you. We'll go to the next slide. So care continuum significance for data. So since 2015, HRSA has used the care continuum to demonstrate efficacy and the need for the Ryan White HIV/AIDS program to continue. Comparisons for service care continua with care continua based on all people living with HIV highlight strengths for the program. It can also highlight discrepancies in quality outcomes between Ryan White programs, so those that are higher performance, and then non-Ryan White HIV programs that tend to have lower performance and outcomes. So HRSA has been able to determine that its funded system is very strong and its private healthcare system that is causing low national health outcomes, or there are gaps between Ryan White HIV/AIDS program and non-Ryan White HIV/AIDS program systems that are attributable to these differences. Ideally, we'll be able to create similar comparisons for our region. Next slide, here we go. So this is looking at the 2018 Texas HIV Care Continuum. And so we're looking on the blue bars at all people living with HIV, and on the red bar at those living with HIV that are enrolled in the Ryan White program. So you can see here that at all steps of the continuum that people enrolled within Ryan White parts do tend to perform better with their health outcomes. So they're more likely to have at least one viral load lab for the year. They're also more likely to be retained in care and to achieve viral suppression. Next slide.
I was just trying to unmute real fast. I think this like literally emphasizes all the points made on the last slide, right? That, the HIV service system that we provide in Ryan White outperforms the HIV service system that is in the private sector, because you have to add the two together, right, to create the everyone average. And I think that this speaks volume to the level of commitment that you all have, the level of effort that you exert, and also, the proof is in the pudding, as they say.
And I'd like to just point out on retention of care for the in-care population is always going to be high, right? Because they're in care. So if you're going to do QI around retention, you really need to look at your all, right? Your overall population, because that's where you're going to find the folks that are out of care. And sometimes people get a little lost in that. So they don't understand the differences of the in-care versus the overall population. And it's really important that you understand that. So if anyone has questions, please reach out or speak up now, or you can email me later and we can talk about it. Thanks.
Thanks for catching that nuance. Jesse emphasized it too. My apologies.
In this slide, we're talking about healthcare neighborhoods. So what is a healthcare neighborhood? So it's defined here as the group of service providers available to serve clients in various ways within a geographical area. So some things to consider may be who are the payers or funding, differences within a healthcare neighborhood, barriers to care present within healthcare neighborhoods, maybe perspective of client ownership. I'm sure many of you have experience with this. I know in Indiana we do, where an agency feels ownership over a client because they are receiving maybe some services at their clinic, and they want to utilize that client for data purposes and reporting to the state. And while in actuality, the client is truly experiencing healthcare within an entire neighborhood. So they're not operating within an island of one service provider, but rather operating within a system. So some ways that this can be utilized is interagency planning and coordination of care of groups of patients within a healthcare neighborhood. So across agency or even internally within an agency across programs, really planning the care for an individual so that they receive all that they need within their service region. Some things to reflect on, maybe to consider your own preferences for yourself and how and where you receive healthcare, implications for travel and waiting time, balance with other concerns and needs. I know for myself that I feel most comfortable in places that can provide me with high quality service, but also are always willing to say that, hey, maybe I don't have everything that you need, and someone else that operates within our system can provide it to you. And so that I have the room to seek out where care is available to me. Next slide. So there's many ways to evaluate experience data. So something common that we see within organizations across the nation or and within healthcare systems are comment boxes. So typically there are boxes placed in the lobby where a client or a patient may input a comment. Some important things to consider with comment boxes is that the information is collected and then discussed within private locations and not out in the open within the client area, where people may see you reading and maybe laughing or not taking as serious the comments that are placed within those comment boxes. It's always great to debrief those as well, but you may not develop any quality improvement efforts from comment boxes. Satisfaction surveys are another great way to collect experience data, and so some considerations to those may be how often do you have those? Are they for one individual service or for your entire agency? Are they sent out through mail or something a client receives via email or at the time of their service? Focus groups can be great to collect evaluation to evaluate experience as well, where you would host a group of people together to talk through whatever program or system that you're seeking to evaluate with set questions, but also allow the openness to collect or for the conversation to be guided by the people within the group as well. Town halls and listening sessions are usually much larger than a focus group and are typically done for a community versus one single entity to collect larger scale qualitative and experience data. It can also be a way to collect feedback as a system when you all work together around how you may all integrate care and services better within your region. Key stakeholder interviews can be done at entrance into care or exit out of care. There's plenty of other ways that you can utilize those as well, but they would be to identify just individuals that are key stakeholders within your program or within your network that you would want to interview to collect some qualitative and experience data about their entrance or exit into your system of care. And then of course, there are other ways to evaluate experience data. Michael, do you want to touch on any other ways that maybe you've utilized in the past?
In the interest of time, I think that we can move through. But I think that there are so many ways that you can think about this. And the great thing is to tap into your own humanity. As we saw on the last slide, thinking about healthcare neighborhoods and thinking about what has been helpful and timely for you when someone where you get your care or a very important service to you is engaging with you, and kind of like how that felt. Because so much about this, as Jasmine was mentioning with the comment boxes, it's about creating a target place to capture all of your rotten tomatoes. And so just the process of squeezing out the rotten tomato is an important thing psychologically. That resonates with all of us, right? So just thinking about it in those terms and tapping into our own experience, I think is just so important.
Yeah, I think another point too is that these methods can be used to evaluate patient experience, but also your staff experience within your provider programs. This is a great way to collect feedback from staff around opportunities for improvement, or just, for them to be able to let out maybe some frustration. Next slide, please. So all of the next few slides really dive in deeper to some of the things that we've really already discussed. So again, that idea of the rotten tomatoes for the comment box, to be able to just give people the opportunity to express how they feel. And it may be great and it may not be great. So comments can be red flags that can be tracked and followed up on, but they're not necessarily things that you need to run and make huge system level changes about. We can do next slide. So again, looking at satisfaction survey, this is the most common way to evaluate experience, and many agencies and systems do provide satisfaction surveys. Again, there's the idea of time. So is this a continuous thing that someone can enter or input at every entrance point into your system of care, or is it something that happens periodically, like maybe in the summer and then again in the winter? So you try to base your survey questions on validated questions. From my experience, developing surveys can be a very difficult task at times, because you don't want to drive anyone to answers that you're seeking, but you really want to allow the space for people to really tell you what it is that's happening, and be able to utilize that to make changes possibly within your agency. Next slide. So again, looking at focus groups, this is one of the best ways to drill down on the comment boxes and survey results more in depth. So they do need to be structured in a specific way. So are we getting feedback from key populations of focus? How can we ensure the various populations have the same low barrier opportunity to share? It needs to be carefully facilitated using a structured tool and a set of framing questions. And groups are best done within 5 to 10 participants, so everyone can participate, and there are enough diverse opinions for participants that they can bounce off of each other. Diving in deeper into town halls and listening sessions, again, they're very similar to focus groups, but much, much larger venues. It can champion of all voices, and the perspectives are important here within town halls. And it is critical to have a sense of what the outputs from these meetings will be and what will happen for next steps. The community would really want to know what you're going to do with the information that you gather from these town halls, and they'll probably want follow-up on how you utilized it and applied it, and what were the outcomes of that.
And just real fast, thinking about your role as an administrative agent, this is something that you could potentially do to help champion this activity among the providers in your area, is that in the name of creating and establishing or fortifying a healthcare neighborhood, to bring together a group of key stakeholders, consumers and otherwise, to really talk about what are the high points and low points about the way that we have designed our service system, so that we can best identify those opportunities. And in looking at the chat room, I'm excited by some of the comments that I saw Jesse making, because that's exactly right. By then taking quantified information and bringing it to this group to share, then you're giving them the opportunity to say what that means to them. So who is missing, who is overrepresented? These types of questions are really critical as a community for us to come to terms with, in order to understand what is actually happening, what could be happening, and how do we improve to get from where we are to where we would like to be?
So diving in deeper to key stakeholder interviews, again, these can be done as entrance interviews for patients that are new to your service, or for exit interviews for patients that are maybe leaving your care, they're transferring, they're moving out of state, or any other reasons that they may leave your care. During change management, so for patients and staff to provide feedback on change ideas as they are being implemented within your providers. Networks or within your larger AAs. And then staff interviews, they can be great to consider for new staffing and exiting or departing staff, and they can be added to as needed. Brings us to some time for discussion. I don't see any new questions in the chat box, but
I saw Julie's point though about AAs being at various points and trying to examine their experience evaluation programs and tech. So I'm wondering if there's anything that anyone on the call would like to share that's been, you know, a high point, a low point, a sticking point.
I don't call anyone out, but I get to review everybody's CQM plans and all their, so I know, for example, BVCOG has that as a standing item on their quarterly meetings. And I think it's a best practice in a way that you don't forget to review it with others and not just read them and not do anything with them, right? But I agree with Jasmine and Michael about you got to take the responses with a grain of salt. When I was the nurse at a clinic, some of our responses were so out of line. Some folks would, I think I got a response once about how, you know, the question was, how could we improve services? And it was to have naked dancing nurses. So things like that, obviously implement that. But, you know, there were a trend of wait times, right? That's an issue that we can work on. And if there's so many people complaining, then that's something we should probably look at.
So, hi, this is Oscar. Another situation that I would like to share with the group is the response rate. It is very challenging, and we are experiencing at this moment that kind of thing. The response from the clients sometimes is very difficult, and it takes an extra effort to get that information in a valuable way. Just a comment.
I totally agree. Back to the clinic, it's easier when you're in the direct patient care realm than the AA or at the state level. But for an example, the way we achieved higher response rates in the clinic was to show them the responses we got. We put them on a big board in front of the scale where we weighed the patients to show them we're listening and we're paying attention and we're making actions based on this. And it's during a time when we're already standing on the scale with them anyway, and no one wants to talk about their weight. They want to look at the pretty poster board with this patient.
Anything else? Anything else? That's a really, really, really smart tactic, you know, and it speaks to that concept of building trust. You know, like, why do you want this information? Are you really going to use this information? Are you just asking me this to play a gotcha game? Are you just asking me this to kill time? You know, building that trust and like demonstrating to people how their feedback is so important to actually drive progress, I think is such a wonderful way to do that. But it takes time. It is not done at a snap of the fingers, and it's not done overnight. It's an iterative process that takes time to build.
My screen is glitching. It's really weird. Sorry. Next slide. So in this section, we're going to talk through some QI methodology.
So here we are at another poll. I'm going to go ahead and open up this poll for you. And similar to the themes of other trainings we provided so far, we're just curious, how many times have you been trained on this before? This is not a new topic in our area for many, but we want to make sure that we have a sense of who this might be their first time, who's been trained a little bit, and who's been trained many times. And then secondly, we want to ask if people have a level of confidence about the difference and the nuances between QI methods, approaches, and tools, because these are critical differences and they can cause a great deal of confusion and frustration in the field when we're trying to put our best foot forward and we can't even agree upon what it is that we're freaking talking about. So we just wanted to get a sense from you. What is your level of comfort? And if we could get another 6 or 7 people voting, that would be amazing. Keep those votes coming in. This is a safe space. There's no reason to be shy. And of course, we continue to create our trainings based on the responses that you give, not only in the evaluation, but in these portions as well. It's very important for us to know where you all are actually at. Okay, 3 more seconds. All right, so let's share these results. So it's good to see that this is actually, most of you are middle of the road. It's not your first training, but you haven't been trained out the yin yang yet. I think some of you probably have been trained out the yin yang, and thank you for your patience for being here and for listening to these hopefully different perspectives on something that's important to all of us. And do you feel confident in the difference? This is fascinating to me. Half and half split. People feel confident and they don't feel confident. So I'm really excited for this next piece that Jasmine's going to launch into to help to uncover some of this for us all. So thank you so much for participating in these polls. Again, it is so helpful, and I'll turn it back to Jasmine.
Thank you. Next slide, here we go. So, sorry guys, I don't know why every time I'm on a call with you all, my screen glitches. It never does this. I think we skipped one slide, Michael. Yeah, there we go. So looking at quality improvement strategy, recipes for success tend to be robust stakeholder involvement on the quality improvement project team, having communication of progress and sticking points beyond the quality improvement project team, and strategic alignment of project aims with organizational vision and mission. And this is always really important to not only help with alignment within your organization, but just to bring people back to what is the real mission and the vision of the work that we're doing here, and how can everything that we do be in alignment with that. Common challenges for quality improvement strategies tend to be remediation of low performance is QA, not QI. And addressing monitoring site visit findings is compliance, not quality improvement. Unable to resist the urge to constantly run around and put out the next fire. And never-ending projects or confusion on how to sustain these gains once the improvement effort is made. Methodological approaches. So Michael sort of hinted at this earlier, but there is this operational focus versus performance focus. So within operational focus, it is tied to excellence in strategic processes. So typically this is scored within your OA. It can be tied to excellence in quality culture management, i.e. time. Whereas performance focus is tied to endpoint outcomes. So your model for improvement effort, for instance, and then tied to eliminating waste. So I know many of you probably identify with Lean Six Sigma and ways that we can work to eliminate the waste there. So there are those differences, both play a role, but we have to really acknowledge, like, what are we doing here? Are we focused on operations? Are we focused on performance?
Right. And for trivia fans, PCN 1502 says that quality is focus on HIV endpoint health outcomes. Therefore, clinical quality management is very much preoccupied with performance focus. And so that's why we have the model for improvement listed as one method, Lean Six Sigma listed. But these other pieces for operational focus are also important approaches for us to continue. And the method that we have in Ryan White is the organizational assessment, which I think is familiar to almost everyone here at this time. And there's a couple of other methods that are included here. The toolkit will include references to all of these, so you'll have a chance at your own leisure and comfort to go in and to review and to take a look to see what these are.
Diving deeper into the model for improvement, there's 3 strategic questions that are followed by PDSA cycles, and those are here on the slide. So what are we trying to accomplish? How will we know that that a change is an improvement, and what change can we make that will result in the improvement? So PDSA cycles can inform or modify strategic answers. Questions plus PDSA cycles help to encapsulate the QI project life cycle. So you're setting aims, that's your discovery. You're setting measures, so you're fleshing from discovery learnings, identifying change ideas, so taking root causes really into account, and then testing those change ideas, which would be your implementation. Other methods to pursue, you may also pursue QI methods outside of the model for improvement, though that is the methodology that the state has outlined for subrecipients and sub-subrecipients to utilize. But they should, so other methods that you seek to utilize should be fully described within your CQM plan. And they should have a performance focus, so your organization's quality improvement activities really speak to the HRSA-wide QI activities, and relevant reporting is available. And Julie says that you do all allow for a mixed method approach, so you can all seek to utilize other QI methods in addition to the model for improvement. Well, mixed methods are okay too, as long as they are described within your CQM plan. So other than model for improvement, Lean Six Sigma, in addition to healthcare derivatives of these methods are the most common across national Ryan White HIV/AIDS program systems.
And my apologies, where it says EMA HSD wide, it should say statewide. My apologies for that oversight.
It's okay. Julie says that she also uses Lean. Lean templates in concert.
University health system, and they use Lean, and so I was super comfortable with it. When I came to the state, they really focus on PDSA, but you can use some of the tools and use them in a PDSA. And so whatever works best for you, but we do recommend highly the PDSA model for improvement at the state.
So methods versus tools. It is a common error to confuse methods and tools. Methods have a prescribed order of activities and fidelity to the process is needed, whereas tools can be used across methods and for multiple purposes. So kind of the essence of what Julie was discussing, there may be some tools from other improvement work that can be utilized and across multiple purposes, but methods are very prescribed and are true to a process. The model for improvement is so much more than just the PDSA cycles. The PDSA cycles are a part of the QI project life cycle. So they are the testing of change that occurs. Testing change is implicit to the performance-focused QI methods that we talked about earlier. Other cycles that are similar to PDSA cycles are the DMAIC cycles, which Michael really taught me about recently because I haven't used them much in my work. But if you have questions around those, I'm sure Michael could answer this.
Jasmine, I had a private comment that there are some new folks that may not know what PDSA stands for.
Oh, plan, do, study, act cycle. So that is the model for improvement methodology. So PDSA cycles are the same thing as PDCA cycles. Oh, Michael went backwards. There we go.
Yeah, I went backwards to be able to show how the
Yes.
cycle works and how testing change is related to the model for improvement. A lot of times people will say, what improvement methodology you're using? And they say PDSA. PDSA is a part of the model for improvement, but PDSA is not the method that you're using.
Right.
If you're just testing changes without having a discovery process, you have what we call a do-do cycle, because all you're doing is doing stuff. You're not planning, you're not really studying, all you're doing is doing. And that speaks to that urge that we talked about before, to always rush and put out the next fire. And what happens when you do a do-do cycle everywhere you go? Well, you don't need me to cuss on the recording, so I won't, but you get the drift. Yeah, I think that's where we had been. So I'll go one more here.
Yes, one more. Thank you. So looking at the QI project life cycle, again, we have this discovery, the root cause, and then we're really implementing this change. And you can relate this to within a medical system, typically as assessing, diagnosing, and then intervening. So it's just another way to think of it. So many of you or your subrecipients may be involved in this work and recognize it from the viewpoint that is used with the medical care of assessing, diagnosis, and intervening. And with the QI project life cycle, then it's very similar with discovery, root cause, and so this dives in deeper into, Michael, my screen's still glitching and I can't read this slide. Could you help me?
That's okay, no worries. Technology can be our friend and it can be our foe. So I am very happy to pinch hit here. So this is from the Public Health Foundation. You can see that it's the Public Health Quality Improvement Handbook. I think that this is an amazing tool, and I always carry mine with me everywhere I go in my handy dandy workbook. Just proof is in the pudding, right? So this is actually showing you how different tools are used at different phases of the QI project lifecycle. So, you know, this life cycle has a lot more steps than the three that we had shown. The discovery, root cause, and implement, but you can still see discovery, root cause, and implement along this pathway. It's really important just to think about flow charts appearing multiple times. Run charts, control charts, pie charts are all tools that we use to talk about a current state and to identify ideal future states. And there are different processes that we use with these tools to identify how to get from our current state to our future state. And it's really important, again, to think about. People will say, what is your QI method? The answer is not flowcharts. If someone says, what's your QI method? The answer is not Pareto diagrams. You know, those are tools that you use as a part of your QI project. And the QI method is actually probably the model for improvement, or maybe lean. And very unlikely would it be Six Sigma, because I don't think any of us really have the volume to do Six Sigma meaningfully. But this diagram really is just to show you that tools can be used at multiple times in a QI project lifecycle, and is again intended to help you see the difference, the nuance between what is a QI method, what is a QI approach, and what is a QI tool.
Thank you. So within our discovery phase, let's make sure I wasn't We do have standard work that happens. So it's the work that we do as part of our job descriptions that is rooted in performance measurement. QA activities or quality assurance activities, for those new to us, like peer review or supervision, may identify an opportunity for improvement. Performance measures may also identify opportunities to improve. Identification of those disparities and other nuances is also included in this discovery phase, but not all issues are elevated to QI project level. Sometimes small adjustments can be made without a formal QI activity, right? So typically our quality improvement, our model for improvement is utilized within something that requires small tests of change because it is a larger system level change than just making small itty bitty improvements within the daily work.
Cycles and cycles.
Root causes and drivers of change. So just because we identify a need doesn't mean we know everything about that need on its surface. So we need to dig deeper to get to the heart of a problem. Root causes and drivers cannot be identified without the help of stakeholders. So typically when you're doing root cause analysis or driver activities, you tend to do these in a team setting with a multidisciplinary team, or and also inclusive of consumers of your service, because they're the people who are going to really help you drill down and get to what is really the root cause of the issue here and what are really going to be our drivers for change as we move forward. Root causes lend themselves to drivers that can be tied to individual change ideas intended to address the root cause or to facilitate the driver. So when implementing tests of change, implementing change ideas through test of change is not as easy as it sounds, unfortunately. We need to carefully plan our test of change and not just rush to do the test, because then we end up in our do-do cycle.
Right.
Test one change at a time based on a prioritized list of change ideas. So the rule of one. We're testing one change at a time. So maybe you start with one provider for one afternoon, then you utilize that test of change with one provider for a whole day. And then if that is effective, then maybe we roll it out to 2 providers. And so you want to make these small incremental changes to see if this change is really going to have this the effect that you're looking for and be sustainable.
Yeah. So for those of you who have been trained on this topic before, this slide probably resonates with you because you've seen the rule of one and that diagram that CQI uses to kind of show how this expands. For those of you for whom this is your first training or you're less familiar with that, you might need a little bit more context behind this. So we invite you to put your email in the chat room so that we can send you links to some of the CQI Quality Academy materials that will give you some of that more remedial backup that you may be lacking if this is your first time at this rodeo. The discussion. This has been a very quick overview of both performance measurement and QI, thinking about the lens that you have as AAs. And so entire courses are written about this. So there might be things that, are still unclear to you, or something that was clear previously, but now seems, nebulous. We would just love to give you the opportunity to raise forward any other questions or concerns that you have about this, either on the air or in the chat room.
So when it comes to PCN 1502 and the required or expectations around performance measurement based on utilization, you shouldn't really be measuring just to measure, right? You should be doing something actively to improve the outcomes. So if you're utilization shows that we should be measuring, let's say, referral for healthcare, and the performance measures we selected are above 95 consistently, then we should probably select a new performance measure, correct? Or
Absolutely.
measuring these things and showing them at our committees, but what do we do with it, right? We need to look at it. Can you talk a little bit about analyzing the performance measures and using them in QI, like how to, like focus a little more on that?
Sure.
Coming
So-
up next.
something that is really important is to think about how you can unpack a measure that is an annualized measure and to make it focused on the time period that you're looking at. So, I consider these to be bellwether measures, right? An annualized measure that's looking at 12 months of data will talk to you about the average of that 12-month period. But in terms of making a change on the ground today, I can't continue to go back to that 12-month measure to see a change that I made. So that's a secondary piece to the question that Julie's raising in terms of how do I identify what measures are the right measures? And I think that, starting with the care continuum is a great place. And then going from there conversationally using your stakeholders in terms of identifying what other opportunities or gaps are there in the services provided and the quality outcomes that you would wish to see, you can unpack it conversationally in that way. So I would say that there's really not a hard and fast rule about how you select your measures, other than making sure that the measures are selected in a way that is taking into account all the different feedback and the perspectives of your key stakeholders. Some of the work that we have going in Dallas right now actually has us working with subrecipients of funded services so that they can help us identify what specifically they are wanting or feeling is most important to measure related to the services being provided in their area. And I think another really important thing to keep in mind is that, your performance measures can be tied to a qualitative measure in addition to being tied to a quantitative measure. So if you end up finding that, for my referral services, there's not really a clear way for me to get at the care continuum data, maybe we can ask a survey question that helps us to populate and to better clearly understand what's happening for folks of that service. Then you just have to keep in mind what Oscar said earlier, Rome's not built in a night. And so you have to be patient as the data slowly trickle in and that evidence base slowly builds. Because again, it's not like you're gonna put a survey out and all of a sudden have 1,000 responses at your fingertips. Does that help, Julie?
Yes, thank you.
Yeah, absolutely.
Anybody
The most important
have
thing.
questions? Everyone's so quiet. I can't believe it with all the questions we always have around performance measures.
I wonder if people aren't feeling shy to ask certain types of questions, because we've been doing this work, for a while, and it's like, I wonder if people feel as though they are putting a spotlight on themselves by asking a question. And I can't emphasize enough how that's not the case here, that we are a friendly group of folks that are really trying to help Texans with HIV to have the best possible outcomes in future. And we acknowledge and respect all the amazing contributions that you have and that you're making to accomplish that.
Michael, this is Brian. I'll put myself out there. In terms of selecting performance measures, I'm working with Julie on the evaluating the CQM plans, and that's a new thing for me. And not like I'm an expert, but one of the things I noted, and I think might help the field, is it's not just 1502, but also what she had mentioned to me was also think about when you're looking for measures and the epidemic type of measures as something to consider, because I think it can get a little bit overwhelming when you're trying to select a measure and you want to be thoughtful and you want to put something that's going to get the biggest return on your investment. And so I wanted to put that out there. I didn't know that, but I think just sharing that with the group might be able to help, because that's also, unfortunately, that's something else you have to think about, because, okay, I've got 1502, I need to look at utilization. Oh, but then also this, so.
Yeah, I really value that, Brian. Thanks for sharing that. That the idea is that just because, and I think this actually speaks to why the state, why DSHS has said that even though medical case management doesn't arise to the level that PCN requires there for there to be a measure, they're like, we're going to go ahead and measure that anyway, because as far as we're concerned at the state, this is a critical aspect of the care that we're funding and providing across our state. And we need to understand what's going on here in order to be able to make a real difference. Great question.
I just would like to add something. This is Oscar Solina from Dallas. I'm the CQM program coordinator in Dallas, and we are having we've been working with Michael and the support from Julie and Brian since 2020, the beginning of the 2020. And yes, I got that feeling, okay, should we open up and express all the obstacle we have locally? But well, we conclude that definitely we have to. And it's a safe place. It's a place that when you drop an information, you get feedback, a positive feedback. So I encourage everyone on this call, please bring it on. This is a safe place, and it's very helpful to bring those details that actually block you to achieve that performance measure that attach with the cascade, that quality of the data that you're not having. We don't have that, and we still working on that. And thanks to Michael, that we being heard. So I encourage you, everyone, do it. It's a safe place, and it's a full beneficial. And this guy has so much experience that blow your mind. Thank you very much.
Thanks, Oscar. Well, I want to make sure that we still have time to get into your portion of it, and to share with us what you have been doing as far as your activities as an AA. So if you don't mind, I'm going to keep the slides down and ask everyone to go ahead and turn on their camera so we can have a conversation. And what I'd like to do is to call forward specific groups to share with us. And what I can do is see if I can create in the chat room, I'm going to plop the questions that we're all answering. That way we can all see what questions we're answering. Will that work? All right. I'd like to call forward our friends from, let's see, let me make sure I get this right. The Pan West and West Texas, the Star Care group in Lubbock, to share what they've been doing or what their thinking is as far as achieving together is concerned, and how some of the quality activities that they have going in their region might play into achieving together. Who's going to present for us from the Pan West?
Hi, this is Maria. Can you hear me?
Maria. Yes,
Hi,
welcome.
I don't even know if you can see me or not. Sorry.
Maria, hola. Turn on the camera. There you go.
There she is.
I always turn on one and forget the other. Okay. We have our quality management data manager on the call, Bob Schaefer. I don't know if he's ready yet to present or not. And I was hoping our planning coordinator would be on also, but she had another meeting, and she's also in the midst of getting out some client surveys. So I'm giving Bob a chance.
Bob, are you with us?
He's there with us for just a sec. I see his name, so I know he's on the call.
Is it Bob Schaefer?
Yes, sir.
Let me see. Bob, I have asked you to unmute, sir. Hi, Jesse. Jesse's waiting for our presentations. Bob may have stepped away, Maria.
He might have.
This is Dennis Kinman. I'm the program coordinator there in Lubbock, And
Hi.
I suspect that Bob, I had a phone call come in, and there was somebody needing some help at our El Paso location, and it was semi-urgent. So I'm about to leave for an appointment myself, but maybe you could loop back around and catch up with us in a few minutes.
Sure, that will be okay, I think. Let's go ahead and move to South Central Texas then, and I'll restart the clock. Who's joining us from South Central Texas that can tell us a little bit about their thinking as far as achieving together is concerned? South Central Texas. So this is the Bexar County Hospital District.
Okay.
Julie, who do we have from Bexar County Hospital District?
Rhonda Andrew.
Yes.
Hi, Rhonda.
Yes. Hi, sorry, I didn't realize we were referred to as South Central. But yes, I'm with University Health System in Bexar County, and I actually went ahead and did the whole PowerPoint presentation and answered each of your questions. So I'm the program, CQM coordinator and the planner as well. And we have a pretty comprehensive CQM plan. We've gone through a little bit of adjustment over the years, but this last year was pretty much our first year to really implement our CQM plan based off of PCN 1502 and really trying to get into there and align it with a lot of the different things going on with EHE and our fast track cities. But the first question that you had there with which target population we're working on, and so we utilize the disparities calculator in order to really drill down on that data. Yeah, and it was really informative because number one, we found that data, we had to actually kind of exclude quite a few charts because the data was not current. So that's something we'll be working on with our quality assurance and with our data team. But with the charts that were relevant, we actually found that one of our groups that we really need to focus on is youth of color, 13 to 24 MSM. The funny thing is the viral suppression is all over 90%. So of all of them, they were still the lowest. But still, the concern there really is them getting into care before their HIV status progresses to AIDS. Even we have quite a few that have already progressed to AIDS when they come in for their first visit. So it's like, okay, that's a problem. So that's how we are. That's one of our main target populations we'll be working on. We'll also be looking. We even did an analysis of age 50 plus, just because that's half of our population. So we want to see where they're at. We're going to do some further analysis on that, see if there's some other areas that we can help in that. Then your second question was outcomes that we hope to achieve. So seeing as how the entry of data into our lead data source is actually kind of lacking, we hope to achieve better techniques in timely data entry, just because that's so relevant. You know, that I've seen so many entries that it'll just barely miss the mark by 6 months, but it's like, you know, we need that information as soon as possible. Then another thing is discovery of new methods to reach youth of color, and then, of course, increase viral suppression rates. Then question 3 is relevant to how our CQM plans aligns with the Achieving Together plan. And I had to pull out my Achieving Together plan and look at that again, just to see what those activities are. And so our plan activities actually focuses on reducing HIV transmission through addressing viral suppression, and then of course trying to increase the viral suppression. We first research and verify the data, then by teasing out the target populations, we're able to identify what a focus needs to be and who can lead those activities. So usually identifying responsible parties, Sometimes it might be one agency as compared to another agency because their target population is more relevant. And sometimes this also includes education. So this will address cultivating a stigma-free climate, which is one of those focus areas of the Achieving Together plan. And then that also helps identify health disparities that might exist. And one example is our oral health care initiatives. We were able to deliver an oral health education, found out that most of the people that attended was case managers. So now we're going to take that a step further and try to educate clients. But that was really helpful to see what kind of information needs to be shared and how to tailor that.
Very well done. Thank you so much for that report and for sharing. And Jesse, is giving some feedback in the chat room that it's very interesting. And when I worked on the In Care campaign, the population 50, 60, the further up you go, you have to think about optimal wellness. And I think I got really excited thinking about geriatric models of care and how geriatric care models could actually help to influence and improve the way that we think about medicine, overall in the United States. But I think more to be seen as folks like you do great work in the field to help to champion this population and this issue to help end the epidemic. Thanks, Rhonda. Okay, so who do we have next? We have Central Texas, the Brazos Valley Center of Government.
Hello. So I talked to our planner yesterday to get information about this. She's out today, but I think I can stand in for her. So the key populations we're working on. So we have a big part of Texas. So it's different in different parts of the state. So so whether it's in North Texas or along the border, they're different. It's very different. So we depending on which HSDA we're in, it's different. So so that's a big part of why it's targeted in different places. So that's the answer to the first question. And a lot of what we've done this year is focusing on our community input meetings, which we've had to do via Zoom this year, because that's how we roll at this point.
Yeah.
And so so we're adapting because that's what we do. We still have to carry on business. And so we have we've not had a lot of great participation in these Zoom meetings, and the reasons for that are varied, but we'll figure that out as we go. And so I think, so one of the things that we have from the input we've gotten is seems to be some disconnect between staff and clients, whether it's case managers or whichever staff. So one of the things that we want to do is provide some training to staff along the lines of cultural competency or stigma. So we're still working on figuring that out. And so Matina has some contacts with folks at Texas A&M. So she's going to institute some listening sessions for our staff at our agencies. And so that would be over and above the cultural competency training that they're required to take for their contractual requirements. So we want to focus on stigma training. We're still working on that to flesh that out further, but that will lead into the ending the epidemic goals, because that's stigma is part of that. And so our quality plan, most of our goals are tied to viral suppression, and most of them are HAB measures, so we can get that data very easily through ARIES. Let's see. So we're still working on, so our agencies have some QI projects, and they report on those in their semi-annual reports, but we don't necessarily have one that everybody's working on. We are working on a project with creating equity, so that we're a part of that collaborative. So we will, the project that we choose, we will, I guess, make all of them participate in that is probably too strong, but we will strongly recommend that they all participate in our 154 counties, so that we can increase everybody's linkage to care and viral suppression in all of our giant area. So we will have a QI project designed soon. Let's see. So I think we're getting there. So I think we have a lot to do with our activities, but we're getting there.
Yeah, it sounds like you all have. Thank you so much for sharing that. And here comes the timer right now. So perfect timing. Thank you for sharing that. I think it's so important for us all always to recognize how big and diverse Texas is. Like 154 counties in Brazos Valley COG, and that's 50% more counties than we have in all of New York State. And that's just your area. Wow. And so I think that you're very wise in terms of thinking about the high level of variability across your region, and you're allowing for people to be able to tell you what's important based on their involvement of their stakeholders. And that is super excellent. I think the idea that you're leveraging additional external activities to help you, like in a Coxon style way, to call strokes in the community so that we're all heading toward the same goal in tandem is very, very powerful. And I think that, you're in a similar place as many folks who are trying to herd the cats in a large geographic area using something like Zoom, and I feel as though there could be support groups for people like you set up for individuals all across the country who have been really, really, really struggling with this. But I applaud the efforts that you're making, and it sounds like you're doing some really great work in your area. So thank you so much for all of that. Okay. Who do we have next? Next, we have Northwest Texas and the Tarrant County region.
Hi, everyone. I'm from Tarrant County, Caitlin Lopez. To look at the population, so not only do we focus on the Achieving Together and the Texas HIV plan, we are also an ending epidemic jurisdiction. So we also follow that very closely as well. We have an amazing data analyst who has really outlined where and who our population needs to be tailored to. At the highest point is our Black MSM population, then is Black women, and we also are working with the Latinx MSM population as well. Those are the key focus populations that we will be focused on. Let's see, your second question was, what outcomes are you hoping to achieve? We have a variety of outcomes. Like I said, a lot of the Achieving Together goals about stigma, reducing overall, incorporating, reducing barriers and all that kind of stuff. We have those built into our QM plans, our subrecipient, sub plans. And with us, all of our subrecipients are actually asked to do 2 quality improvement activities a calendar year. And so those are all supposed to be tied to one of these strategic domains as well. And they must incorporate people living with HIV. It's a big part of what we recommend in all of our plans. Let's see here. So we have quite a few quality improvement projects going on. We also just recently started using Life QI to help us manage all of the different subrecipients and the different quality improvement, as well as quality assurance projects that are going on at one time. It's a really neat dashboard that allows us to track progress real time and show us the measures that really need more specific attention. A lot of actually 1 to 2 people from each subrecipient has had the ability to attend Lean Six Sigma and receive their certification. So we're super excited about that. We wanted to kind of leverage the traditional PDSA cycle, but also incorporate some of that lean, removing of waste. And so all of our subrecipients are now well informed and have been certified as a green belt at minimum to ensure that we're kind of leveraging all different types of resources. We also work to get a lot of our subrecipient agencies IHI open school licenses, so that way they can use some of those quality improvement resources as well.
That's fabulous. And I wonder, Caitlin, if you'd be willing to share the process that you undertook to kind of tap into similar feedback for you, that what you're doing is you're trying to make sure that you're not recreating any wheels, and you're also leveraging the free or otherwise available technical assistance and coaching packages that are in the system. And that's brilliant. And I'm wondering if you can share any sense with folks, like how you went about creating those opportunities.
Yeah, and Lisa has a lot of really great information as well. So Lisa can feel free to jump in and add anything. But we felt that, when you're with PDSA, it is something that it's tried and true. It's worked for many, many years, but there's still areas to improve, right? So what's the definition of insanity? Doing things over and over the same. And so coming in and looking at more lean models allowed us to kind of just take a different approach. And so we wanted to first, we actually had quite a few listening sessions, and we revamped what's called HIT HIV. It's our health improvement team. It's a cab of only HIV positive individuals. And through feedback, we really learned about health outcomes and what our clients within the community were experiencing. And so we determined that we needed to create new models to help show subrecipient agencies kind of where those deficiencies were. And if we kept doing PDSAs, we really weren't hitting some of those areas. So we looked at lean and then looking at the green belt certification to ensure that we weren't, like you said, we weren't recreating the wheel. We were investing in things that were going to improve our processes. And so far we've seen really good improvement based on kind of some of those new skills, kind of connecting. When you look at Lean and Six Sigma, sometimes people are like, oh, this is more of a business model, but there's a big tie into healthcare, and kind of, if you're not looking at the word waste and you kind of change what that word waste really means in a healthcare setting, it really impacts many areas through the care continuum.
You're taking me to church, and I love it. In terms of thinking about waste as defined as defects in Six Sigma, waste as defined as anything that does not bring the customer joy in Lean. That's where the money's at. And as someone who's living with HIV for 20 years, thank you so much for being an amazing champion of the community and the community's voice. Thank you for your leadership.
I wanted to add just one quick thing. When we introduced the concept of the green belt opportunity, our subrecipients weren't interested. And we typically got feedback after a day, because it's a 4-day, full day training. And we got feedback the first day that people didn't think it was applicable. They were worried about the math. But when they hung in there, they really saw that connection to the healthcare and developing, even if they don't pass their certification, they have developed those tools, which is beneficial.
Yeah. And I think also it's just kind of, so in our larger QM meetings, we then also relate back to, okay, these are some Lean or Six Sigma topics that we've talked about or learned through our training. Now, how do we implement them in a clinic or in just a ASO that offers food and housing? So trying to really connect those dots for them.
Thank you so much for that. We really appreciate it. Next, let's hear from our friends in Northeast Texas and the Dallas area.
All right. Angie, do you want to start, or do you want to fill in, or how do you want to do it?
You can go ahead. If I need to jump in, I will.
Okay, thanks so much. Well, here in Dallas, we are in the process of revamping and remodeling the whole CQM system since 2020. thanks to Hager Health and the team and the support of the Part B partners. We are remodeling basically from the CQM plan, the goals, every single one. The performance measure, it's a new way to put it together. So we come up with the service categories that has more utilization, and out of those, based on the PCN 1502, have those decided for the groups, which is basically conformed by the subrecipient staff, if they're going to be qualitative or quantitative performance measures. We have done 6 service categories that has higher utilization between 25 and 50, and outpatient ambulatory is the only one that has more than 50. But we have transportation, non-medical, medical case management. We have outreach, and some of those service categories don't have an easy way to track the quantitative. So that's why we come up with the idea and the support of the subrecipient to do qualitative on those pieces. We are in the process of that. As far as performance measure, really that it's coming out very nice, because we're utilizing a platform called Qualtrics to use those qualitative measurement in 2021. And as far as client satisfaction survey, we decide to do one cohort, like a year, one sample a year, like December, for example, everybody will be happy with the agency. So there will be no problem.
I like the way you think, Oscar.
99% satisfaction survey, but you provide them food and basically you exchange. Okay, yes. So we decided to instead to do that. So every time, like once a month, we create a survey, and that the patient will provide this the feedback from that agency, and we are in a pilot test process at this point with the client satisfaction survey that we want to call the client experience to avoid bias. And as far as the organizational assessment, we are revamping that and detaching from quality assurance, quality improvement. So we are dividing that piece and making the line very thick to determine those two that has different concepts. That's one of the huge step in remodeling the system, because it's an old practice. So it's very difficult to move people out of the common habits for decades. So we are doing that too. Another one.
Do you have a priority population that you're focusing on?
We are looking for that. Angie, if you want to chime in into that.
As far as I know, we haven't gotten to that point yet. We haven't identified a priority population. We were starting to begin working with the disparity calculator that Michael developed, but hopefully we'll get to that part soon.
Oh, okay, sorry, I didn't mean to interrupt.
Yeah, no, it's not an interruption really. It's just part of the planning that's coming on, because previously we collect the data from areas, but we determine the data on areas is very incomplete. So that's the first step to determine priority population. We need to have a van, and we are having that issue in the details of the priority population. In the past, evaluation was strongly focused on youth, transgender. That's the main big ones, and then another two were of color and women. But again, based on data, we cannot rely on that practice to do it, and we can refine that process and remodel that.
Thanks so much for sharing.
Yes.
I think, yeah, I think that the important piece to point out here is that there's no shame in being in a discovery process and in kind of looking at the cards where they are on the table and figuring out your next move from there, and not overpromising and letting the process be the process, letting the process lead ourselves to the data. And that's what we're doing right now. And sometimes when you revamp things, it just takes a minute for it to kind of come back together. So there's no shame in that. Thanks so much for sharing.
Thank you for giving me the chance.
Yeah. Next, we have Houston Regional in East Texas. we have a representative on the phone from East Texas and Houston Regional? Okay. Let's move
No,
on.
Tiffany was here earlier. Tiffany, are you still on?
Can you hear me?
Yes.
Hi, Tiffany.
Oh, you can hear me now?
Oh, you became
you
very
kinda-
quiet. Let's see. Good old technical difficulties, right? Tiffany, we'll come back to you in just a second. Let's move on to South Texas, the Valley. And I saw Maribel was online earlier. There she is. Let me unmute you, Maribel. Okay. Perhaps
Actually,
Maribel.
Erica Garcia is their QM champion at STDC, although might also be the presenter, I'm not sure. But usually our QM go-to.
Hello, well, good afternoon
Erica.
to all. Hello. Sorry for that. Yes, well, let me tell you, let me put this on because I can only hear myself. Okay, so we're working together. Right now what we're doing is, what we want to get our outcomes are working for viral suppression and detention in care, which are the goals that we have also for Achieving Together and the other plans. And then we are also collaborating, we're working with the ECO Collaborative and also with the CQII, with the Equity Collaborative that we're working right now. And Dora was going to help me with other stuff. Dora, can you please?
Okay. All right. Can you hear me?
Hi, Cindy.
I don't know why my name is Dora.
Your child says Cindy.
I don't know why.
At the top,
It's weird.
right?
Well,
Okay, your name. But
Dora, right?
yes.
There we go.
Dora.
Hi, Dora.
Dora. Well, Erica was talking about that during the first, I think it was like 2 years ago, we started getting together to see the differences between the goals and the objectives of the regional plan, the QM plan, and Achieving Together. And by 2019, with the needs assessment results, we were able to update our needs assessment like at the beginning of 2020 with the goals not only about viral suppression, retention of care, but also we added the Achieving Together plan goal of eliminating a stigma and getting more collaboration from other agencies so we can partner with all of them and help our community to be aware of HIV, but also to prevent viral, to advocate for viral suppression and improve acuity results. We have been doing activities together, but also with the QM in the QM meetings, it's very particular of each of the areas, the activities that they have to plan. And we try to get all the activities going towards the same objective, or to find benefits for all of the results will benefit all of the goals that we have in each plan. And our challenge, as always, they may say, oh, the complaint is always there. But one challenge that we have is that our service providers in our area sometimes don't understand the connection that is between all of the activities that we have to do. Like, for example, if I receive a phone call from a client saying, they're not helping me because I have health insurance, but I need case management services. And then I call the agency and they will say, well, we cannot see them because they have decided that this client doesn't need case management and they already are self-sufficient because they have health insurance. So things like that, they don't find the connection, like why we do, like in delivering a services can have a connotation and a result in all the measures and the results that we are trying to find.
Yeah.
So I don't know if I explained it well because it's something kind of.
Well, no, I think that what you did, I think you did describe it well. And you know, I received a comment about that in the background as well, in terms of thinking, you know, from another participant on today's call, who is basically saying that what do we do when we have providers that are, sometimes it's hard not to think that they're purposely trying to not understand what's going on. And it's easier for them just to deal with in front of them and to hell with whatever else is coming in. I don't have the time or interest to engage my population. Do not be digging through my data. I will not have the time to explain it to you. And no, the data's wrong, not my performance. I mean, this is a really complicated issue. And it's one of the reasons why I think the state is providing this training, is so that we can start to think about this, not just in terms of more words, because there's a lot of words out there, there's a lot of trainings out there, but what we need is frameworks, systems to help people, to reach people's hearts and minds, to help them see their potential. You are a part of a system, you are not an island. You are not funded to be an island. And I think that this gets to be really challenging for regions like yours and regions like Brazos Valley that are so extensive, because they're like, what do you mean that I'm a system of care with someone who's 10 counties away? And it's harder for them to make that connection than it is in a city. So I applaud the work that you do in these, you know, outer areas, you know, to be able to help people to see their connectivity to something that is less tangible for them, just by the definition of your service area's vast borders and boundaries.
Yes, or sometimes the same thing happens when, for example, they're working on the PTS in their PTSA. I mean the project that they're doing with where the monitoring, after the monitoring and the evaluation. And in the meantime, we ask for how do you perform or how do you deliver services under this particular category, especially on case management, when they have to meet some criteria, and they found it difficult to explain in terms of how they deliver the services, but they sometimes will say, well, we're doing good because we're having the same amount of case managers and we're paying them and we're doing great in expenditures. But what about how many clients have you served? How long have you seen them? Are you doing a quality time with them and achieving the measures that we want to see, or the success that we want to see in this particular client? Follow-ups are very difficult to meet, and things like that. But thanks God we're working as a team, and I'm very glad with our DSHS consultant and Julie and Brian, and all of us are being very supportive to us. And I'm thankful because I think we are achieving something that was in our needs assessment requirement. I mean, one of the results was that we need to work more as a team and open more the communication with providers, and I think we're working on that. And it's been a success.
Well, thank you so much for sharing that, Dora and Erica. And I'm sorry about getting your name wrong. I think I have it right now, finally, as we're about to wrap up. But you know, we didn't have time actually to hear from Houston or from West Texas. We can circle back to that in just a moment. But what I wanted to bring your attention to is, in order to honor the time commitment that we had made, I have the evaluation up, just so that we can get that responded to. We're already 2 minutes over. So if you do have to go, please do go answer the questions first if you can. If you have other points or concerns that you'd like to raise in the chat room, please feel free to plop them there before leaving. But I would like to circle back at this time to see if our partners from Pan West in STAR want to share a little bit about what they've prepared for us today. Hi, Bob.
Hey, how you doing?
Good. How are you, sir?
Good. I guess we'll just go through the questions real quick. Pan West is 66 counties in West Texas, ranging from Amarillo all the way through El Paso. we don't have any kind of monolithic or ubiquitous population that we can really identify. So we kind of focus on, I mean, obviously, you know, people in Amarillo, that client is going to look a lot different than El Paso and Lubbock, Permian Basin, all that. So in general, we just kind of focus on those at HSDA and try to look for unique, problems that they did or they have there. I just completed a quality improvement project and started another one for our area. And the first one was it was all focused on data integrity. So when I got there was all kinds of problems and things going on. And so I sent surveys out to the providers, you know, the people actually providing HIV care, to see what the problem was, because I was looking at inconsistent data, missing data, all that kind of thing. I did interviews. I called them up and did key interviews. We met in person, even some. And so I got some ideas, and it came down to they didn't understand. There was different places. They were putting data in different places in areas. And so the HAB-QM report wasn't picking them up. They didn't like the HAB-QM report. They thought it was not working. So I spent a little over a year doing training on that, talking about data integrity, talking about how to enter it into areas, doing training that way, and talking about going through the HAB-QM manual, saying, look, if you want your viral load suppression numbers to be picked up on this report, you need to make sure that this data is entered here, and that these other indicators are also fulfilled. And you just make sure they're entered here, and it'll come up. And so since when we did that, data integrity is a lot better now. And the HAB-QM numbers went up, mostly about 15%. And so some of these things we're doing well. There are some weaknesses, and that's part of the second one. The second one that we're working on now is oral health, because I've got one provider that the HAB-QM report is reporting 2.5% for oral health indicators, and they have they have problems all across Texas with this. And so right now the quality committee meeting is focused on trying to look at how to improve oral health numbers, both in practices and also in performance for the indicators. So those are the things that I've been working on since I've come on.
Thanks so much, Bob. Tiffany is actually asking if there's any documentation that you can share that you use to help train people. And I'm, as someone who's a big data nerd, himself, like, I love the fact that you use key stakeholder interviews and that this was a very structured approach. You help them to take one step after another to see that this is a problem, what their role is in the system, and so how they have a skin in this game as far as the problem is concerned, and then helping them you met them where they're at to champion them along. If anything you can share would be amazing.
Right now, I mean, I've got some PowerPoints archived, and
hey, that would grand. I think that would be really, the more that we can have, a central basis for kind of thinking about these issues, the stronger that we'll all be. I saw Oscar stepped away right now, but he was looking very intently as you were speaking, because he went through the data integrity, a similar activity in Dallas in 2019. And that actually is one of the reasons why we decided to just kind of like smash the glass and start over with related to the CQM performance measurement in Dallas, because there were too many concerns and issues and too many roadblocks. As we were saying, our providers sometimes know how to use our own passions against us and to say things like, oh, Aries isn't set up in a way that makes sense to me, therefore I'm not going to use it. And then it's incumbent on us to kind of like hold our ground and to say, no system's going to be perfect, but we have to use the resources that are available to us. So let's see what we can do to make this work for us as best as it can. And you did a wonderful job with that.
Well, I mean, I kept hearing over and over, Aries is broken. Aries is broken. That's what they kept saying, Aries is broken. And I found out what that meant was the reports that were available, a lot of them weren't working anymore. So I went in and fixed some of them. And then I started writing reports. You know, people were having problems with care plans. So I wrote a report, you know, tailored to each provider based on what they wanted. So they could run reports and see their care plans, see their acuity scales. They could pull all kinds of data in these little snapshots, because a lot of times if you go and you run STAR or something, it's 2 screens of stuff to put in, and that can be overwhelming for people. But I've got some PowerPoint training I can send out. If someone wants to email me, I'll email them to them. I can't share my screen here. So, you know, if you want to send me your, you know, let me put
Bob,
my,
I can set something up and offer it to all the AAs, and whoever wants to join us, join us.
well, I mean, you can just look and see what I did. It's nothing that big, but that was
But
my
it works.
first,
It's good.
well, that was my first thing. And they're getting a lot more out of Aries and out of the HAB-QM than the other reports.
Well, thank you so much, Bob. We really appreciate your presentation and for sticking around to share with us. Now, we only have one more to hear from. So Tiffany, let's see if the mute button's going to be your friend now.
Can you guys hear me?
There she is. Hey.
All right. I thought I was being fancy and I put headphones in, which completely sabotaged me.
Dun, dun, dun.
Yeah, sorry. I'm under the weather, so I'm going to decline on my camera. But just super quickly, for our area, we are the 51 counties in East Texas, and our target populations really haven't changed much over the last couple years. So under 24, minority women, and then gay and bisexual, minority men, gay and Black and Hispanic. And it similar to everyone else's areas, it kind of does depend on the HSDA. So some HSDAs are slightly different in what they're going to focus on. For this year, we're super excited. We're doing the Create Equity Collaborative with the focus on mental health. So that's going to target the Achieving Together mental health focus. Internally, we're also working on just better coordination within our AA. We have a really awesome consumer involvement department, awesome planning department, and the information doesn't always cross into our QM processes the way they should. So this year, we're going to work really diligently to get all of that consumer feedback fed into our QM program a little bit better than it has been in the past. In addition, for our quality management plans across the different agencies, this year they're going to have at least one of the same goals. We're going to pick it, everybody's going to agree, and that is going to be the one that'll be continuous through all of our agencies, and then they can do whatever else they want to do after that, with the focus on viral load suppression. We're also finishing our EMR project. Essentially, the focus of that was to ensure that everybody use their EMR to the highest capacity to assist in client care. And so that's using the patient portal, that's outcome reporting, that's telehealth, and we have one more provider to finish with. A goal of this year is to work on stratified data. That has been my crux, and it's been really difficult to pull that out of Aries. And so if anybody has any tips or tricks that don't involve like buying an entirely new database, please let me know. And then for ETE, our Part A area got those funds. And so we're really just coordinating with them as a community partner, and anything that we can kind of, do across our region, we definitely are trying to. There's been a little bit of a slow start, obviously, because of COVID. And culturally appropriate services is in the Achieving Together. We're definitely targeting that this year because of an issue we had in 2020. So making sure that all of our subs are adhering to LAP rules and regs is at the top of our radar for the first quarter. And just building capacity. We had started doing quarterly capacity building with our subs, particularly the ones that were participating on the QI committee. But I think I'm going to dually do it and just do a snapshot we have a monthly provider meeting. So monthly provider meeting gets the snapshot, the QI committee gets a little more in-depth capacity building. I think that's it. I'm trying not to keep you guys.
That's wonderful. Thank you so much for sharing all this with us, Tiffany. I think that in hearing the presentations across all of our administrative agencies, there are so many parallels happening, in different corners of the state, whether we're focused on helping the subrecipients to really understand what role they have in our system and how they can help us best to achieve our system goals, or whether we're working on better championing consumer perspectives, or whether we're focused on, a common issue like viral suppression. There is a lot in common across the state. Also, Texas is, I think, the most significant participant in Create Equity. So you have so much common ground within administrative agencies and across your administrative agencies to explore regarding this. And I think it's a really exciting time to continue this discussion in Texas. I'm really inspired by what I heard today, and I'm really grateful that you all were able to come to this training and to share what you're up to and what your experience has been with this. So thank you so much for joining us, and thank you for filling out the evaluation. Thanks for all the wonderful supportive, for being so supportive of each other and of our state leaders. I see a lot of love and accolades for Julie and Brian and Rhonda and others. So thank you everyone for all that you do and for trying to end the HIV epidemic.
Yes, and thank you, Jesse, for joining us. You have so much knowledge that we can learn from all your years of experience, and then the planning side that we often miss, and we really need to work better together. So thank you so much for guiding us on some of the talks.
Thanks, everybody. This was really helpful and informative. I think, like, listening to it, I didn't want to take up time, but I have a ton of questions to follow up with Julie and Brian, and then to reach out and talk to the planners about overlap between planning and QM and processes and community engagement strategies and stuff, to make sure that we're not duplicating, that we're all working in concert and complementing and sharing and not creating false boundaries between QM and planning processes, because there's so much overlap.
Well, if I may, one of the things, we have one more session to go in February, and that session is on how AAs can provide technical assistance, coaching, and capacity for our subrecipients. And I think that to continue our focus on this lens and our focus on achieving together will really be a wonderful way to think about the type of coaching and technical assistance we can provide as AAs to our subrecipients who are providers in the field. That way we are being very, very, very focused on how we're providing guidance all to the same end. So thanks everyone. Happy Friday. Have a beautiful weekend, and we'll see you soon.
Thanks. Bye, everyone.
Thank you,
Bye, everyone.
Brian.